So we're continuing with this topic of the early neonatal life. So this transition from fetal life to neonatal life, which is really the core of the physiological differences between the neonate and even the older infant or the child or the adult. Okay? It's that we have these very key things that we need to transition from intrauterine life to extrauterine life. And so we talked a lot about things like establishment of continuous respiration, the change in the circulatory system, and the closure of the shunt in the heart. We talked about independent thermoregulation, and we mentioned establishment of oral feeding in that topic as well. So today we're going to focus on the establishment of oral feeding, okay, and the digestive system in the neonate. We're going to talk about glucose homeostasis. We're also going to talk about some key differences in renal function of the neonate, okay, and the implications for that in terms of management of the neonate. And we're also going to talk about the neonatal jaundice topic, which relates to liver function, and liver function is very relevant for glucose homeostasis. Okay, so those are the topics we're going to talk about today. So in terms of leading up to this concept of the establishment of oral feeding, we're going to talk about the changes in the digestive system from fetal life to neonatal life. So anatomically, in fetal life, the digestive system actually develops very, very early. Okay? It's one of the earliest organ systems to develop during the fetal period. And the reason that it develops so early is because, and we've looked at this before, but this circulation of amniotic fluid in the fetal period is highly dependent on the fetus swallowing a great amount of amniotic fluid, okay, and then passing that fluid through and releasing it as urine. Okay. So fetal swallowing of amniotic fluid and fetal urination is the primary recirculation of amniotic fluid. So as you can imagine, the fetal digestive system actually has to be established fairly early in order for that recirculation of amniotic fluid to occur. Okay. So it happens anatomically, it develops very early. It's anatomically developed, fully developed by 20 weeks. The functional development, okay, also certain parts of the functional development occur very early, and then other parts happen much later, and into actually the maturation after birth takes a considerable amount of time. Okay. But the functional development begins during the fetal life, and that includes the development of the digestive enzymes, okay, necessary to break down substances, and the liver enzymes, also necessary to metabolize substances. Okay. So functional development includes the development of the digestive and liver enzymes and the absorptive surface area. Okay. So that is has functionally developed by about 33 to 34 weeks gestation. Now it's not fully mature, it's just as mature as it's going to be. Okay. As we'll talk about later, the functional development stays fairly immature until about 6 months of post birth life. Okay. So it's not until this baby is about 6 months old that their digestive system gets even close to full functional maturity. Okay? But it gets to as far as it's going to get to by about 33 to 34 weeks. Okay? So during fetal life, the development of the GI tract is not, does not serve GI function per se. Okay? So the kind of GI function that our body performs in fetal life, that's taken care of by the placenta. Okay? So the digestion and the metabolism of substances, digestion is done by mom's digestive system. Metabolism of substances is done by the placenta. Okay? So the baby's only given this pure energy substrate that it can immediately use. But the purpose in the development of the GI tract in fetal life is, number one, to accommodate this recirculation of amniotic fluid. Okay? It's to accommodate this recirculation of amniotic fluid. And then by swallowing that amniotic fluid, it actually promotes the development of the GI tract. So early function of the GI tract, the purpose of that is really to allow for recirculation of amniotic fluid and to promote its own development. Okay. So amniotic fluid is, in addition to having just fluid and water, it's very rich in things like various nutrients, so energy substrate, vitamins and minerals. It's got lots of hormones and growth factors. So when the baby, and of course also lots of cellular debris. So when the baby takes in all of that amniotic fluid and it goes through the tract, those hormones and growth factors and nutrients stimulate the development. Okay. But the caveat is all of the cellular debris that the baby, and hormones and growth factors that the baby is swallowing, okay, it has to get digested, or else it's going to cause it's going to cause bowel obstruction. Okay. So a lot of this stuff that's in amniotic fluid that's actually got a very high protein content needs to be digested, or else this fetus is going to have bowel obstruction. So the ability to digest and transport protein develops very, very early. Okay. By week 14, this baby can break down protein and transport amino acids. Okay. So the GI tract actually physically and functionally develops fairly quickly in utero. So when I was pregnant, a friend of mine sent me this picture because she thought it would be a good depiction of my child because of the coffee of life. But but I thought it was an interesting depiction of amniotic drinking. Anyway. Okay, so once the baby's born, now the function of the GI tract has to develop into the function that matches the adult GI tract. So this baby now has to establish feeding and start motility through the GI tracts, more adult-style motility through the GI tract. It needs to start breaking down the food that it's consuming and absorb the food that it's consuming. Okay. Now GI function in the neonate is limited, has physiological and functional limitations that are pretty significant. Okay, pretty significant. And this is for a normal, healthy term, full-term neonate. Okay? All of these limitations are exaggerated in a preterm baby. So keep that in mind. So we're going to talk about what these limitations are, but the limitations in general increase the risk for things like dehydration, reflux, malabsorption, and electrolyte imbalance. Okay, so baby is really vulnerable, even under the best of conditions, for these things, for dehydration, reflux, malabsorption, and electrolyte imbalance. So these limitations involve, number one, limitations on the absorptive surface area. Right? So the mucosal barrier through which we absorb food, digested food, is very immature in the baby, and it remains immature for the first 4 to 6 months of life. Okay? So the absorptive surface area is immature. The ability to produce digestive enzymes is limited. Okay? And the motility through the GI tract is altered. So we're going to talk about what the implication for each of these are, what the details of this is. So first of all, this immature mucosal barrier. Part of the immaturity of the mucosal barrier is that the baby actually has the ability to absorb certain macromolecules. Okay? So this is very different than the adult or the older child, because for us, we cannot absorb macromolecules. Food has to first be digested. So proteins have to be broken down into amino acids. Carbohydrates have to be broken down into monosaccharides, right, like glucose. And fats have to be broken down into fatty acids, okay, in order to be absorbed. But for baby, the baby, because of the immature mucosal barrier, some macromolecules get through. So some fragments, polypeptide fragments can get through, some triglycerides can get through, some smaller carbohydrates can get through. Okay. And that is both beneficial and creates risk in baby. Okay. It's beneficial because it helps compensate for the immature digestive enzymes, okay, the fact that it doesn't need to break down everything it consumes. Okay. However, being able to absorb macromolecules, it increases the risk for infection. Okay? Because if food macromolecules can be absorbed, so can pathogens. Right? It also increases the risk for food allergies. So certain very pro-allergenic foods can get into systemic circulation much more readily and can potentially trigger allergies. And I can tell you that this is becoming more of a controversial topic. In recent years, there has been this belief that early introduction to pro-allergenic foods increases the risk of food allergies. So there's this delaying of the introduction of certain foods like nuts and strawberries and foods that have a high frequency of allergies in the population. There's some research to suggest that that's not necessarily true, that the early introduction of these foods don't necessarily lead to increased risk of food allergies, but it's still a very poorly understood topic. Allergies in general are a fairly poor understood topic. And the assumption that early introduction of these foods causes allergies is also fairly controversial, yeah. I don't know the specifics of that. It sounds very familiar. I don't know the specifics of that. I mean, generally speaking, babies who are breastfed have fewer food allergies as an adult, but that may be because they're being exclusively breastfed and they're not being introduced to these foods early on. So I'm not quite sure how to answer that. Yeah. Yeah. Well, I can't recommend anything as a practitioner because I'm not a practitioner. But as a mom, right? I tend to think that what people do is a cultural norm where they come from is probably just fine, you know, with certain exceptions. You know, there's certainly, you know, in some places children are, you know, it's not uncommon to give children like soda and soft drinks and things like that, where, you know, that becomes a problem. But yeah, there are certain cultures that will give children table food, the full spectrum of table food, very, very early. And they don't seem to have the same problems with food allergies. So, you know, if I were speaking not as the practitioner to that mom, just mom to mom, I would say if it's a norm in your culture, it's probably fine. But, yeah. Yeah, well, the recommendation that is a responsible recommendation by clinicians is to try to delay solid food until 6 months if possible, with the exception of some children just need to consume more than breast milk or more than formula earlier than that because they're constantly hungry, right? They just need more calories. So, I mean, the general recommendation is to delay solids until 6 months. Yeah. Mm-hmm. Yeah, you're asking really good questions, and you're asking the questions that I have to tell you as a mom is like trying to make decisions without having like a strong cultural influence, you know, dictating what I do. This is what all moms are facing right now, is this, like, if you have access to information, you are confused, you know? No, it's really true, because you're being told by everybody who is an authority that that the first meal should be, you know, iron-rich, enriched grains, right? But then there's all of this other information that suggests that might not be the best food for your children. And so if you are an informed person, you're confused about what to do. Yeah, I mean, I know this is really inappropriate, but I can tell you personally, my daughter didn't eat any of the grains. You know, her first food was avocado, and that's right now her favorite food, you know. We actually aren't doing anything except, no, really, we just decided we just wanted her to eat food as it comes out of the ground, you know what I mean, like as it really looks like in the world. And so she ate avocados and a whole selection of pureed vegetables and fruit, and that was what she ate, you know. And then, but you know, they're getting most of their nutrition from breast milk or formula anyway. So the early introduction of food, or the initial introduction of food, is to supplement calories, and also actually to get them used to oral feeding that isn't a fluid, you know, and it imprints their food preferences to a great deal, you know. So pushing the veggies early on is, anyway, so that's personally what I did. I had lots of people who told me that it greatly imprints their food preferences going into their toddler years, you know. So that's very well documented, that the foods that they eat early on become the food types that they prefer when they're a toddler, and then into childhood, which makes sense, right? That's what they like. And when they go into like the toddler years, they get into these like, I'll only eat this, you know, for weeks at a time. So if you can squeeze a vegetable in there, you know, it's pretty good. Anyway, but that's just my personal completely inappropriate to say thing about, about that. But it's very confusing what choices you make, and then what you say to your patients as a clinician. You really can't say something necessarily that goes against, what you're sort of mandated to provide your patients with, So it's a very difficult topic for parents who are fairly well informed and want to do the right thing. It's a very difficult landscape to navigate, as is pretty much everything else about raising children. Okay. So these macromolecules that the baby can absorb, generally speaking, it does increase their risk for GI pathogens and food allergies, or at least that's the prevailing thought. They also, the maturation, their postnatal gut maturation is highly stimulated by these very specific GI hormones, and that includes hormones like gastrin and neurotensin. Okay? And those hormones are released every time the baby feeds. So when the baby consumes food, these hormones are released, and it promotes the further maturation. And it just so happens that consumption of breast milk tends to promote the greatest release of these hormones that mature the GI tract. Okay. And breast milk actually also contains growth factors that further independently stimulate GI maturation. Okay. So with the establishment of oral feeding, a healthy full-term newborn is fully capable of breastfeeding immediately after birth. Okay? They should be fully capable of breastfeeding immediately after birth. The success of immediate breastfeeding postnatal can be influenced by drugs that mom took during labor and delivery. Okay? So some drugs have been shown to affect latching and successful breastfeeding, especially in the hours immediately after birth. Drugs like Demerol have been associated with difficulty with latching and successful breastfeeding. So there are factors that can affect that early latching and early breastfeeding. Okay. Babies are born with a swallow reflex, right, where something gets into the back of their throat and it triggers a reflexive swallowing. And that develops during fetal life between week 28 and 30. The sucking pattern, okay, the reflexive sucking, babies are born with that, and it matures within the first 24 to 48 hours. Okay. So babies may have a weak sucking early on, and then by day 1 to 2, that improves. Okay. That also tends to be the timeline of when milk is coming in, right? When breast milk is coming in postnatally in mom. So by the time milk comes in, baby's sucking like a champ. Okay. And infants have two types of sucking needs and two types of sucking patterns. They have what's called nutritive sucking and non-nutritive sucking. And not only is the goal of this sucking pattern different, the actual physical actions of these sucking patterns are different. So obviously for nutritive sucking, this is the sucking that they will do when they are feeding. Okay? And the frequency of the sucking is about 1 suck per second. And the ratio of suck to swallow is about 1 to 1. Okay? Because with every suck, hopefully they're taking in enough fluid to initiate a swallow reflex. Okay. Non-nutritive sucking has a different frequency, It has generally a frequency of about 2 sucks per second, but sometimes there could be kind of a burst of sucking. Okay? So the frequency isn't this like stable frequency like you see with nutritive sucking. It depends on the wakefulness of the child, whether the child has fallen asleep or. But it's a non-stable pattern, or excuse me, a non-stable frequency, and the ratio of suck to swallow is about 7 sucks per 1 swallow, right? Because they're not taking in anything that's triggering a swallow reflex. It's just the buildup of saliva that's triggering the swallow. Okay, and non-nutritive sucking is a need that babies have. Okay. It's a need that babies have. It provides them with comfort. It stimulates the development of glands in the under the tongue and in the mouth. Okay. It's actually an essential need for baby, this non-nutritive sucking. So this establishment of oral feeding is a very important part of this transition from fetal to neonatal life, okay? And anything that affects the establishment of oral feeding is going to have significant effects on many of the other topics we're going to talk about, okay? So not having this well-established oral feeding can affect hydration, it can affect blood glucose levels and cause hypoglycemia, it can promote can cause neonatal jaundice. Okay? So this early feeding and adequate fluid intake are associated with decreased bilirubin levels and a lower risk for jaundice, okay, among other things that we're going to talk about. Yeah. The amniotic fluid swallowing is happening before the reflex is actually there, and so it's not a reflexive swallowing. It's a little bit different. Before that swallow reflex is fully developed, it's really more of an increased pressure going down, right? Okay. So one more thing before I move on from this. So babies are born, and mom is immediately producing what kind of, right, mom's producing colostrum. And so the production of colostrum within the first 2 days, it's a much more concentrated milk, right, has a much higher concentration. The volume is much lower, right? And so when, by the time the milk comes in, right, 2 days or so later, this baby's been consuming far fewer fluids. If you have exclusive breastfeeding, far fewer fluids than the baby was in utero. Right? So it's not uncommon for babies to lose up to 10% of their birth weight within those first 2 to 3 days. And it's mostly a water loss. It's mostly because of a decline in fluid intake. Okay? And so some loss of birth weight is normal even when establishment of breastfeeding is successful. Okay? And usually that's recouped very quickly after the milk comes in and the baby starts consuming milk. Okay? But yeah, that's okay. The home birth babies. Go ahead, what were you going to say? Let's hear your theory.
Well, I was doing with less drugs, less intervention, giving supplements, which is more effective, and maybe they're actually getting a higher level of cost.
I think that so I think that my theory is similar to your theory. So home birth generally, I think in addition to there being obviously fewer interventions in the home birth, not that there isn't any necessarily, but clearly fewer interventions. I also think that the breastfeeding support is usually much better, right? That the getting the breastfeeding going successfully postpartum is usually done much more successfully at home. And it's not necessarily a function of being at home, it's more actually a function of the practices of home birth midwives, right? That tends to be their practice, to not just put the baby to breast and say, see you tomorrow, you know what I mean? That it's more like, you know, that they're not going to let you go until they're really clear that things are happening successfully, and then they're going to follow you. So getting that oral feeding and that latch, getting a really good latch early on and a successful breastfeeding very early is going to get more fluids into baby and have them lose less body weight. And I'm going to sort of build on this as I go through, but there is a cascade of events that happen, and it's very common, that lead to, even before baby's 1 week old, lead to many women just giving up on breastfeeding, you know, or at least creates a huge barrier to reestablishing breastfeeding, you know. And so one of them is that if the initial latch and the initial feeding is delayed in any way, baby's starting to lose weight immediately from as soon as they're born, right? And they're dehydrating immediately as soon as they're born. So keep that in mind. We're going to build on that as we go through. Okay, GI motility. So movement through the GI tract. There's altered movement through the GI tract. This is after birth now. Esophageal motility and the lower esophageal sphincter motility is lower in the neonate, especially within the first 12 hours, but really within the first 3 months of life. Okay? And so that creates an increased risk for reflux and vomiting. Okay? And if by the time your baby is 2 weeks old, you don't have baby vomit covering everything, your baby is a champ in terms of their esophageal motility and lower esophageal sphincter tone. Okay? Very common. That spitting up is a function of that. In addition, gastric motility, so in the stomach, motility is also decreased, which creates a delayed emptying time. Okay? So food lingering or milk lingering in the stomach, in addition to low esophageal and lower esophageal sphincter tone, that really promotes that spitting up or the vomiting. Okay. Breast milk tends to actually empty from the stomach more rapidly than formula. So that's one thing. And I think one of the reasons for that is breast milk tends to have a higher water content than formula, okay, especially during certain times of the day. Intestinal motility in the neonate. Intestinal motility is also slower. So milk is going to move more slowly through the small intestine compared to the older child or the adult. And that's because the movements, the muscle movements in the intestine in the newborn is more disorganized. You have less coordination among the muscles in order to create nice peristaltic waves. On the other hand, so motility through the small intestine is slower, but motility through the large intestine is actually faster. Okay? Motility through the large intestine is actually faster. So if you look at that in combination, the prolonged transit time through the small intestine is good because it increases the time and opportunity for absorption. Okay, so baby's going to have more opportunity to absorb as much as possible, but that increased movement through the colon increases the risk of dehydration. Okay. Yes?
Is it faster in the colon because it's more mature, or is it faster in the colon as
The faster transit through the colon is actually reflects immaturity, that those muscles are just, yeah, exactly. You have this spasming of those muscles. You know, and if you guys ever been around newborns that are early neonates that are defecating? You could hear it like across the room, right? It's like jet-propelled defecation, and it's really because the mass movements that are driving those bowel movements are just sort of spasmodic, yeah. And because the feces is also very watery, right? It's not, so they're not solid. Okay. The first bowel movement or passage of anything through the first stool, that's what I'm looking for, is called meconium in the neonate. And passage of meconium is really an essential step to establishing intestinal function and highly dependent on the establishment of enteral feeding. And meconium is this bizarre stuff. It's just this sort of very dark colored goop that comes out. And it's really everything that was in this baby's digestive tract, the baby's colon, in utero. And it consists of things like cells from the vernix, squamous epithelial cells from the surface of the skin, occult blood, there's bile, and other intestinal secretions. Right? So it's just all of the solid matter that this baby has been swallowing throughout its fetal life. Some of that has not been getting passed into the amniotic fluid. Okay? It's been kind of coating the intestine, okay? Creating this sort of gel coating of the intestine in utero. So the passage of meconium is an essential step for the initiation of intestinal function. Initially, meconium that gets passed out within the first few hours of life is sterile, fully sterile. But by the time 24 hours has passed, if meconium gets passed at that point, you can actually see some bacteria has colonized or is contained in the meconium. Okay? Because immediately after birth, the baby's GI tract is going to start to get colonized by bacteria it comes in contact with. Okay? So most term infants will pass meconium between 12 to 24 hours after birth. Okay? Some pass the meconium earlier than that, right? Some pass meconium after that, but most will pass it between 12 and 24 hours. Delayed passage of meconium is associated with elevated bilirubin levels and the occurrence of jaundice. Okay? And that sometimes happens when baby doesn't have successful establishment of oral feeding. So at birth, immediately at birth, the intestines are sterile, okay? But they very rapidly get colonized. having the gut colonized by normal gut flora, right? The normal beneficial bacteria that live in our GI tract. It's a very important mechanism, number one, against colonization by GI pathogens. Okay? So the presence of normal flora creates an environmental competition for GI pathogens. Okay? So it protects baby against that. It also enhances certain intestinal function, like the synthesis of vitamin K. Okay? Synthesis of vitamin K is highly reliant on gut bacteria. So this colonization of the gut occurs in two stages. The first stage happens immediately after birth and continues for the first week of life. And this is completely not reliant on the establishment of eating. Okay? And it's regardless of diet. It really is whatever organisms the baby is exposed to after birth starts to colonize the GI tract. The second stage, which happens between weeks 1 to 4, is greatly influenced by diet. And what's interesting, and we don't fully understand why. We understand why, but we don't fully understand the implications of this. But there is a difference between the types of bacteria that live in the GI tract of breastfed children versus live in the tract of formula-fed babies. You tend to see a different profile of bacteria. And the reason for this is because the pH of the intestinal environment in breastfed babies is actually more acidic than the environment of the pH environment of the formula-fed babies. Breast milk has a lower buffering capacity for the acid byproducts of bacterial metabolism. So it creates a more acidic intestinal environment. And that acidic intestinal environment is more hospitable to certain bacteria, and that includes bacteria like lactobacillus and I can never say these, bifidobacterium. Okay, so a particular profile of acid-friendly bacteria are living in the GI tracts of breastfed babies, as opposed to formula-fed babies, where formula is much better at buffering acid, so it creates a more alkaline environment, and that tends to promote the growth of other bacteria like enterobacteria. Okay. So what the implications of this are not fully understood. Okay. It's not fully understood what it means to have two different profiles of bacteria. But certainly the types of bacteria in the GI tract it is not a random thing. It is clearly creating a different environment that may have different implications, but we don't fully understand that yet. Okay, in terms of the function, physiological function, digestive function of the system postnatally. Neonates have limitations on the digestion of every category of food for the first few months of life. Okay. And the primary cause of this limited digestive function is the limited secretion of pancreatic enzymes. Okay. So the pancreas, if you remember, produces enzymes that break down every category of food. So we've got proteolytic enzymes, trypsin, chymotrypsin, carboxypeptidase. They break down proteins, pancreatic amylase that breaks down carbohydrates, pancreatic lipase that breaks down fat. So neonates produce a limited amount of pancreatic enzymes. Okay? And The pancreatic enzymes, the digestion of all categories of food are highly dependent on pancreatic enzymes. So there are some compensatory features here that allow the baby to digest foods in the face of this limitation, but the limitation is still there. On top of the limited pancreatic release of enzymes, we also have less gastric acid secretion. Okay? So the baby's gut pH, or excuse me, gastric pH is less acidic. Okay? And that's going to have implications on digestion. First of all, pepsin, right, the proteolytic enzyme produced by the stomach requires a very acidic environment to be active. So in the neonate, the baby has less pepsin activity because the gastric pH is not acidic enough. Okay. So despite the pancreatic limitations and the change in gastric pH, babies can still absorb about 85% of the protein found in milk, in human breast milk. And the fact that they can absorb that much protein found in human breast milk is really a function of the composition of human breast milk, which we'll talk about in a second. Okay? It's a function of a slower intestinal transit, okay, allowing for more opportunity for absorption. And the fact that the baby can actually absorb some macromolecules. So they're not entirely reliant on digesting everything that they eat. So we'll talk about some of the highlights of the physiological limitations for the breakdown of every category of food. Okay, so starting with carbohydrate digestion. Usually in the older infant, child, and adult, carbohydrate digestion is highly reliant on pancreatic amylase. Okay? Does anybody remember what the other amylase we have is normally? Salivary amylase, right? But usually the food that we chew, salivary amylase immediately starts to break down the carbohydrates. But what happens to salivary amylase when we swallow food and it enters our stomach? It gets broken down by the acid, right? So usually the acid in our stomach neutralizes or inactivates salivary amylase. In baby, pancreatic amylase is greatly reduced. However, the baby does produce salivary amylase. And because their gastric pH is actually more alkaline, salivary amylase has a longer life. Right, so that's convenient. In addition, breast milk actually also contains mammary amylase. It actually contains enzymes that are capable of breaking down carbohydrates. Okay. In fact, some of the carbohydrates in breast milk is already broken down before it gets to the baby, okay, because of the presence of mammary amylase. So that's convenient. Then, if you recall, the carbohydrates come into our body in the form of usually polysaccharides or disaccharides, right? Polysaccharides are larger chains of sugars, while disaccharides are 2 sugars, right? The primary disaccharide that baby is taking in is lactose, right? Whether it's consuming breast milk, human breast milk, or formula. So the disaccharides are digested by these enzymes that are attached to the intestinal mucosal lining, right? They're called brush border disaccharides. Does that ring a bell? These enzymes that are actually bound to the membrane of the small intestine mucosal lining. The brush border disaccharides are present at birth, okay? And the baby has an increase in the activity of lactase compared to the older infant and the adult. Okay? And lactase is the disaccharidase, the enzyme that breaks down lactose. Okay. Now, normally, we humans are mammals, right? And so our babies are mammal babies. And throughout the rest of the mammals on this planet, none of those mammals consume milk beyond weaning, right? We're one of the only species of mammals that consumes milk beyond weaning. So this activity of lactase, the ability to produce this enzyme that breaks down lactose, is something that is highly enhanced in the neonate and normally goes down as we age. Okay. In fact, the persistent production of lactase into adulthood is the result of a series of gene mutations in the human population that have been selected for through the continued behavior of choosing to drink milk, okay, into adulthood. Okay. But the human genome originally, without those mutations, could not produce lactase into adulthood. Okay. So lactose is broken down by lactase into its individual sugars, which I believe is glucose and galactose. And so the overall capacity to then absorb glucose, galactose, and fructose is about half of the adult, right? So the capacity to take up those sugars is about half of the adult. In terms of digesting fat, again, pancreatic lipase, in the older child and the adult, we're almost exclusively reliant on pancreatic lipase. You take pancreatic lipase away from an adult, and we immediately start to produce steatorrhea, right? Very, very oily, high fat content stool. We start to lose weight immediately, especially having a difficult time maintaining our weight, so you can end up with wasting syndromes. So pancreatic lipase is absolutely essential for fat digestion in the adult. But in the baby, in the neonate, they can only produce a very limited amount of pancreatic lipase. Okay, it's about 10% of compared to the adult ability. Okay, and then the capacity to produce bile, right, which is a necessary step for fat digestion, is about half of the adults, 50% of the adult. So obviously, baby's getting enough fat, so there's a lot of compensatory factors. Number one, there's just a tiny bit of lipase that is produced by glands under the tongue, linguinal lipase. And in the adult, it's just a tiny, tiny amount of lipase. It's an insignificant amount. But in baby, linguinal lipase is greater. And all of this sucking that the baby does stimulates the production of linguinal lipase. The baby also has some small amount of lipase produced by glands in the stomach, gastric lipase, and in breast milk, in human breast milk, we have lipase that is produced by the mammary glands that we call mammary lipase. So this neonate compensates for a lack of pancreatic lipase by having these other forms of lipase available. So that, in addition to being able to absorb some of the triglycerides, especially the ones that are found in breast milk, okay, helps overcome the limited pancreatic lipase. Okay. So all of these limitations, however, in the physiological limitations in GI function, and just the fact that babies have very small digestive systems, creates this tendency for babies to need to feed very frequently, especially in the first weeks of life. Okay? So it's not uncommon for babies to feed every hour and a half to 2 hours. Okay? And it's actually not encouraged to allow a baby, for example, if it's asleep, to sleep beyond 2 to 3 hours without feeding. And this is a very controversial topic, again, among moms, right? Do you wake a sleeping baby to feed? It was certainly controversial in our house. My husband has a never wake a sleeping baby rule. However, especially in a very, very young infant, their hunger stimulus and waking because of hunger is not always fully developed, right, immediately after birth. So it's possible, and you could have underlying lethargy because of a variety of things, okay? So it is not encouraged to allow a baby to sleep more than 2 or 3 hours without waking it to feed. Okay? Generally, it will wake up on its own when it's hungry, but especially in a baby that's under 4 weeks old, it's not really encouraged to let it sleep. Yeah. Well, other mammals have a very different relationship with their babies. Their babies are generally always found right next to them. And so it's not always necessary to wake them up to feed. So whether or not other mammals wake their babies up to feed is not something I know. But certainly if you're sleeping right next to a breast, right? It's a lot easier to just start feeding and then fall asleep. So it's a very different relationship, right? I mean, it's very different even if you're co-sleeping, right, with your baby. It's a very different situation. Yeah, not always comparable. Okay. Glucose regulation in the neonatal period. So before the baby is born, in utero, glucose regulation is not necessary. Baby doesn't have to regulate its blood glucose. Mom is regulating her blood glucose, and even during the post-absorptive period, mom's blood glucose may fall, but there's continual uptake of glucose by the baby, right? So there isn't a need to independently regulate blood glucose by baby at birth. Before birth. However, at birth, there certainly is, and it's not uncommon for blood glucose levels in the neonate to fall just after birth, okay? And it could actually fall fairly dramatically, and the fall after birth is a result of a combination of factors. Very importantly, the one very important factor is the fact that the liver in this neonate, who's really primarily responsible for glucose homeostasis, is very immature. Okay? And this neonatal liver is much better at synthesizing glycogen, right, taking glucose out of the blood and synthesizing glycogen than it is at breaking down glycogen or making new glucose, right? So the enzymes, the liver enzymes for the production of glycogen are much more active in the neonate compared to the enzymes for glycogenolysis and gluconeogenesis. Okay. On top of that, we have the stress of delivery. So we've got the stress of delivery, labor and delivery. We've got the cooling at birth, okay? The activation of that thermogenesis, the non-shivering thermogenesis, that's going to consume blood glucose. Okay? But all of that stress of delivery is going to, like we said before, is going to trigger the sympathetic nervous system, and that the rush of catecholamines in the body in that neonate is going to help jumpstart this post-absorptive system in the baby. It's going to stimulate the release of glucagon. It's going to suppress the release of insulin. And it's going to stimulate the liver to start breaking down glycogen and making new glucose. Okay. So if you look at blood glucose values immediately after birth, so what we're looking at here is blood glucose in milligrams per deciliter, right? And we expect that for an adult, their fasting levels of plasma glucose is going to be about 100 milligrams per deciliter. Okay? Neonates, immediately at birth, even before the decline, their plasma levels are going to be more like between 80 to 90 milligrams per deciliter. So they're already going to start off a little less than what you would expect for an adult. And then they're going to plummet in the hours after birth. Okay. And then that, so that initial fall is because of all of those factors that I mentioned. The immature liver, the stress of delivery, that jumping up of metabolism after delivery. But if you notice, the plasma glucose is recovering. Right? It drops down to nearly 60, and then it climbs back up. And it plateaus at somewhere between 60 and 70. It's going to plateau maybe 65 to 70 milligrams per deciliter. Okay. So that rise after it plummets and the plateauing of plasma glucose is the activation of this baby's ability to regulate its own glucose levels. Okay, so now it's able to release glucagon, it's able to suppress insulin, it's able to break down glycogen stores, and it's able to activate gluconeogenesis. Okay. Now, even though it's plateaued in its plasma glucose level, the baby and its ability to regulate its blood glucose is generally far less effective than the adult. Okay? And so babies are vulnerable to hypoglycemia. And in fact, their normal blood glucose level is somewhat hypoglycemic, and certainly much lower than would be tolerated by an adult. Okay? So the normal range for blood glucose in a neonate is much, much lower than an adult. If an adult had this blood glucose level, you would see convulsions and major problems. But neonates can handle it. There are certain conditions that can actually deplete the baby's glycogen stores and cause more acute hypoglycemia, more not tolerated levels of hypoglycemia. So things like protracted delivery, Okay, so if the delivery is stressful and protracted, the baby can actually deplete its glycogen stores so it becomes more acutely hypoglycemic upon delivery. Okay. So the sorts of things that are going to increase the risk for hypoglycemia, right? I'm talking about pathological hypoglycemia, not sort of this normal tolerated level of hypoglycemia in a newborn. The risk factors for pathological hypoglycemia include things like hypothermia, excessive evaporation, drafts, and cold rooms. So all of these things basically describe a drop in body temperature and overcooling. Okay? So as we talked about last time, the way the baby really can't prevent heat loss, right? It's very difficult for the baby to prevent heat loss. So it thermoregulates by generating heat, right, through brown fat metabolism. But brown fat metabolism is highly energetically costly. It requires blood glucose. It consumes it. So conditions that force the baby to metabolize more brown fat is going to put it at risk for hypoglycemia. Okay. Babies who don't feed or have poor feeding responses in the early prenatal period. Okay. So a baby that isn't successfully latching, it's not eating very well early on, it's at risk for hypoglycemia. Okay. Stress, especially during labor, prolonged labor, prematurity. Okay. A baby that's premature is going to have less glycogen stores. Okay. And the liver is going to be less mature and less able to regulate blood glucose effectively. So preemies are very vulnerable to hypoglycemia. And for reasons that we talked about previously, maternal diabetes, especially with poor glycemic control, maternal glycemic control, puts the baby at risk for postnatal hypoglycemia. Right? We talked about the hyperglycemia in mom means baby is hyperglycemic in utero, which means baby's producing lots of insulin. When the baby's born, now you have insulin and less glucose delivery to baby. So that's going to cause hypoglycemia. And so some of the symptoms of hypoglycemia in baby, if the hypoglycemia is somewhat mild, you can end up getting excessive sympathetic activation and this jitteriness. Okay? But as it gets worse, babies go from jittery to being lethargic and drowsy. Okay? So imagine you've got a baby, let's say you don't have these problems with prematurity or maternal diabetes or even protracted labor or any of these things. But the baby's having a hard time latching, you're having difficulty breastfeeding early on. The baby doesn't consume enough breast milk and becomes hypoglycemic. Now you have a baby who already had problems latching that's now a little more lethargic and drowsy. Okay? And every time you try to put it to breast, it's falling asleep. Right? It's going to be very difficult to get that baby to latch and successfully breastfeed. So this is one of these cascading problems. So the lethargy and the drowsiness causes more breastfeeding problems and potentially even more hypoglycemia and dehydration because it's not taking in fluids. Okay. This immature liver of the neonate, in addition to having to learn how to appropriately regulate blood glucose, also has to start handling bilirubin. Okay? It has to start metabolizing and handling bilirubin. So the function of the neonatal liver is similar to the adult, but immature. The neonate has a limited ability to synthesize plasma proteins, so it's not uncommon for the baby to actually have lower albumin levels than in the adult, and less ability to metabolize foreign substances. Okay, so metabolizing drugs that may enter the baby's body through the breast milk, for example, baby's less able to do that. Okay? So the substance has a longer half-life in baby compared to mom. So that's something to consider. Together with, so the immature liver processing, in addition to an immature intestinal motility and function, means that the neonate is more vulnerable to hyperbilirubinemia. Okay? Much more vulnerable to hyperbilirubinemia. Okay? Before birth, bilirubin was cleared by the placenta and maternal metabolism, and baby didn't have to deal with it. But now in extrauterine life, it now has to handle bilirubin. And when hyperbilirubinemia occurs, the baby can become jaundice, right, which is not an uncommon occurrence. So neonatal jaundice is a discoloration of the skin and the sclera of the eyes. That's usually more of a yellowish or orangey coloring to the skin or sclera, and it's caused by the deposits of bilirubin in those tissues, okay? And it's relatively common in neonates. And jaundice in the neonate can be a normal, non-pathological finding and just reflect immaturity of the baby's body. But it can also be caused by pathological conditions. Okay? And so generally speaking, before we go on to say anything more about neonatal jaundice, if you have neonatal jaundice before the baby is 24 hours old, that is a pathological cause. Okay? Physiological jaundice, or non-pathological jaundice, does not develop before the baby's 24 hours old. So let's just review the way bilirubin is processed by the body. Okay? So first of all, where does bilirubin come from? It comes from the spleen and its job in dismantling and turning over red blood cells. So red blood cells that are aged, right? Usually red blood cells live about 3 months in the body. But as they get closer to that 3-month mark, their cellular integrity starts to break down. They're sort of old and haggard, and they get trapped in the spleen. The spleen traps those red blood cells and starts to take them apart. And some of the components are recycled and some are eliminated. Okay? So, number one, hemoglobin. So red blood cells are packed with hemoglobin. The spleen recycles the iron and the protein that's in the hemoglobin. But the heme group that the iron was attached to, the heme group, does not get recycled. Okay? The heme group gets converted to what we understand to be bilirubin. Okay? Now, bilirubin is highly lipid soluble. And the bilirubin that's produced by the spleen from the heme group, is what we call unconjugated bilirubin. Lipid soluble. Okay. So bilirubin, because it's highly lipid soluble, and it can easily diffuse across membranes, okay, it travels from the spleen to the liver bound to albumin, okay, to encourage it to stay within those blood vessels. So it travels from the spleen to the liver, attached to albumin, and when it reaches the liver conjugates bilirubin. And what that means is that it attaches a sugar molecule to the structure of bilirubin. The sugar is called glucuronic acid. Okay, glucuronic acid. And the purpose of conjugating bilirubin with glucuronic acid is to convert the overall structure into a water-soluble structure. So unconjugated bilirubin, or naked bilirubin, is lipid-soluble. But conjugated bilirubin, because the glucuronic acid is water-soluble, conjugated bilirubin is now water-soluble. Okay? So conjugated bilirubin leaves the liver in the form of bile. So it's added to bile and leaves the liver through the bile duct. And just like bile is stored in the gallbladder until we consume a meal that contains fat. Okay. When we consume a meal that contains fat, the bile, along with the conjugated bilirubin, is released into our duodenum of the small intestine, okay, where the bile emulsifies our fat. And the conjugated bilirubin now travels through the rest of our small and large intestine. Okay. Now, as it moves through our small and large intestine, some of the conjugated bilirubin is actually going to get unconjugated by an enzyme called beta-glucuronidase, which is produced by, among other things, gut bacteria. So I'll say that again. So as the conjugated bilirubin moves through the gut, some of it gets unconjugated, okay, meaning the glucuronic acid gets unattached to bilirubin. And that's done by an enzyme called beta-glucuronidase. It's written on the slide. And beta-glucuronidase is produced by gut bacteria, our gut flora. Okay. Once unconjugated, it gets absorbed back into the bloodstream, bilirubin. Okay, so that's the destiny of some of the conjugated bilirubin. It gets unconjugated and it goes back into the body. Most of the rest of the conjugated bilirubin gets converted by gut bacteria to this stuff called stercobilinogen. Okay. So some of it gets unconjugated and reabsorbed, and most of the rest of it is going to get converted by gut bacteria into this, it's abbreviated as SBG. It's called stercobilinogen. And I promise you, you'll always remember this because SBG is what makes feces brown. Okay? And that should make sense, right? Because bilirubin obviously has a color to it because when it deposits in your skin, it makes you orange, right? And when the gut gets to it, it converts it to this substance that actually colors your feces brown. Okay? Does that make sense? And everybody feel comfortable with that? Yeah. Most becomes SBG. Yeah. Yeah. Yep. Yes, and then gets excreted. Exactly. it's just a protein. Yeah, a colorful protein. But yeah, it's a substance that can't be reabsorbed, right? And so it gets excreted out, and it has a color to it. Okay, so that is the normal way the body handles bilirubin. So we're going to talk about some of the differences in the neonatal body that increases the risk for this normal this physiological or normal jaundice that can happen. A baby that is healthy has a nice, a white baby that's normal has a nice pink color to it, right? Baby that's jaundice is going to be a little bit more yellow in appearance, a little more orange in appearance. And babies that are not Caucasian, it's a little bit harder to detect the jaundice, but it's going to be detected in the sclera of the eyes, or sometimes the palms of the hands, or the soles of the feet. And so jaundice tends to be divided into 3 different groups, depending on the origin of the problem that's causing the jaundice. It can be prehepatic, meaning that it's caused by problems that are happening before the bilirubin even gets to the liver. Okay. And examples of prehepatic causes of hyperbilirubinemia and jaundice include accelerated hemolysis, so if you have, for example, a disease that causes accelerated attack or death of red blood cells, your spleen's going to be producing more bilirubin, right? Or if you're a baby who had very late cord clamping and then had a higher red blood cell count, there's going to be a period of time in that neonatal period where you're going to be breaking down more red blood cells than a baby with early cord clamping. It's not a problem, doesn't hurt the baby, but it's just something to be aware of, right? So it's an increase in bilirubin production, okay, is prehepatic. Another cause of prehepatic is less albumin, because you have less albumin to bind to bilirubin and bring it to the liver. And we already know that babies have a reduced ability to produce albumin, right? They have an immature liver. Hepatic jaundice is caused by problems at the liver, okay? Or its origin is at the liver. Okay? So individuals with liver disease and liver cell damage or death, like with hepatitis, get jaundice because you have less hepatic conjugation of bilirubin. Okay. Or our neonates, even our healthy neonates, because they have immature livers, are not conjugating as much bilirubin. Okay. Post-hepatic jaundice usually is due to obstruction or delays in the movement of conjugated bilirubin from the liver to the gut. Okay. And post-hepatic jaundice is almost always pathological. So the physiological jaundice that we see in the neonates that's not pathological is usually prehepatic or hepatic in nature. So let me go through some of these points of where you can end up with alterations in the way bilirubin is handled by the neonate that can bring about jaundice. So first of all, increased hemolysis, I mentioned that's excess production of bilirubin. That's going to happen if you have a baby with delayed cord clamping and maybe a greater number of red blood cells, early on. Neonates produce less albumin because of their immature livers, which means you have more free albumin in the circulatory system that can leave the circulatory system and get deposited into tissue. Okay. In the liver, babies' livers are immature, and so they don't have the same capacity to conjugate bilirubin, and that's made even worse if the baby is hypoxic or hypoglycemic. Okay? Any of those kinds of issues are going to worsen this limitation on conjugating bilirubin. Okay? Anything that obstructs the bile ducts, this is mostly going to be pathological, okay, a pathological cause. And then in the gut, okay, babies have a slower gut motility, which means in the small intestine, right, things are moving more slowly. That increases the opportunity for the reabsorption of bilirubin. Okay? So that fraction of bilirubin that gets reabsorbed, that could be a greater fraction in the neonate. And because the gut is sterile early on, you have less gut bacteria that are going to produce that SBG. Okay. Now you add to this a baby that is not feeding well, so is maybe not really producing a lot of stool. Okay. It's going to reabsorb more bilirubin. And there is, even babies who are feeding well, there's actually a type of jaundice that we call breast milk jaundice. And that's a type of physiological jaundice. It's not harmful, but it's a physiological jaundice that we see a little bit more frequently with babies that are breastfed. And the source of that, in addition to all of the immaturity issues that we talked about, the source of that is that breast milk, because it enhances the colonization of the gut with bacteria, it leads to a greater production of that enzyme that unconjugates bilirubin, the beta-glucuronidase. Yeah. Because the breast milk enhances the gut colonization with that bacteria, the bacteria produce more of that enzyme that unconjugates bilirubin, the beta-glucuronidase. Okay. So that's just sort of a quirk of breastfeeding.
Is there any function, or why did we evolve to have bilirubin get unconjugated?
Why did we evolve to have bilirubin get unconjugated? It's not so much a protective feature as just a consequence of the way the system works. Bilirubin gets reabsorbed along with other bile salts and gets added to the production of new bile as a way to limit the need for the liver to constantly produce a fresh batch of bile all the time. So it's part of the recycling of bile, the reabsorption of bilirubin.
So the things that prevent that kind of reuptake, like the cholesterol medication, things like that alter the bile or the bilirubin from?
Yes, it does. Which is just going to put a greater demand on the liver to produce bile, right? The liver can a healthy liver can handle that, but it's a mechanism. Reabsorbing bilirubin and other bile salts is a mechanism of reducing the functional demand on the liver. Yeah. It is. It's going to be considered post-hepatic. Even though post-hepatic generally are pathological in nature, it is going to be considered post-hepatic, but it's not pathological. That's a good point. Okay, so some of the causes of neonatal jaundice. First, I'm going to talk about the non-pathological ones, and then I'll briefly mention the pathological ones. So physiological jaundice, which is usually prehepatic, okay? Usually prehepatic. This is just due to the immaturity of the neonatal system, especially the liver. Okay? And then the jaundice of prematurity, underneath it is an exaggerated form of the physiological jaundice. Okay? So physiological jaundice is just this jaundice that you see with neonates that reflects an immaturity of the system. And that's often made much, is exaggerated in the preemie. Okay. Breast milk jaundice, which is actually under the hepatic sources of jaundice, I'm not quite sure why it's under that. We talked about breast milk jaundice. I think it does actually belong under post-hepatic, but there may also be some action at the level of the liver that I'm forgetting to mention. I'll correct myself if that's true. Polycythemia could reflect that late cord clamping, so it could be a temporary polycythemia as a result of late cord clamping. Okay. Polycythemia means an abnormally high red blood cell count. Or the polycythemia can be an actual congenital problem, can actually be reflect a disease state. The bruising or the hematoma, especially what we call Cephalo Hematoma, these are traumas that can happen actually during delivery. So a Cephalo Hematoma is a bruise that happens on the scalp that causes a lump, right, which is basically a blood clot, a hematoma just under the skin. Okay. When babies suffer those kinds of bruising or trauma of delivery, that bruise or that hematoma has to be absorbed and those cells lysed within the first few days after birth. Okay. So that increased lysis of red blood cells, of breaking down that bruise or that clot, can increase bilirubin production and cause jaundice. Okay. The rest of the causes on this list are pathological, right? They represent disease states. Things like hemolytic jaundice because of RH incompatibility, congenital hypothyroidism affects the ability of the liver to affects liver maturation and function. Okay. Congenital metabolic disorders that affect the liver and congenital anomalies of the biliary ducts can cause obstruction and cause that post-hepatic jaundice. Okay. Mm-hmm. So the polycythemia can be normal in that it's a temporary condition that was caused by late cord clamping. Okay? So it's not normal to have elevated red blood cell count. Polycythemia is a condition that some people are born with, right? And so their bodies tend to produce elevated numbers of red blood cells. But some babies are polycythemic in a temporary way because of late cord clamping. Yeah. Sure? Okay. So let me just make sure that where we are here. So any other questions about jaundice or this topic that we're talking about here? Causes of jaundice. So we started off talking about kind of this, or I introduced the idea that you can have sort of a cascade of things that can happen in the first few days of life that can lead to this sort of great barrier that's created in order to get over, to establish breastfeeding. So, you know, you have some sort of problem early on with latching, whether it's because the baby there was an intervention during labor that created maybe a little bit of lethargy in the baby upon delivery, and then early latching was difficult, okay? Or just for whatever reason, poor support or instruction and latching was difficult. So early attempts at breastfeeding were unsuccessful, okay? The baby becomes somewhat dehydrated, a little hypoglycemic even. The baby can end up being lethargic, which makes further attempts at breastfeeding even more difficult. Okay? The baby becomes more dehydrated, becomes more hypoglycemic. Okay? Now the baby gut motility is happening more slowly. It doesn't have the proper nutrition to support this bilirubin metabolism, and now the baby becomes jaundice. Okay? And at that point, maybe you're 2 days after delivery, the baby's suffering from some jaundice, and let's say it's lost 10% or maybe a little bit more of its body weight. At that point, your pediatrician says, we have to feed this baby now. Okay? We cannot wait for the establishment of breastfeeding. So then the baby gets supplemented food. It gets a bottle, and it gets supplemented with either completely formula or supplemented with formula. And at that point, it's a lot easier to feed a baby with a bottle than it is to then go through what it takes to reestablish breastfeeding or establish breastfeeding. So there's this period of time immediately after a baby's born where a million things are happening at once, right? Where the baby can very quickly get to the point where feeding needs to happen right now if breastfeeding attempts have not been initially successful. So having very good early support to breastfeeding, like a lot of home birth midwives or lactation consultants can do, can really avoid a lot of those problems. But one of the reasons why we don't have higher breastfeeding rates in this country is because we don't support it. It's not a priority to us. So it's getting mom and baby off to a good start very, very early on, and there's a lot of factors that go into that. So there's a real cascade of events that can happen within the first few days of life that make it very difficult. Yeah.
As far as breastfeeding, if the mom, let's say the mom produces milk, but the baby's still pregnant, why not pump and feed the baby through the bottle with the breast?
And women do that. Women do that. So this is a very personal thing for me because this actually happened with my daughter, that we had to switch to the bottle very, very early. So for 3 months, I pumped and gave her milk. And I could tell you that I found a very, very small community of women in the world that do that because it involves waking up for both feedings and pumpings, you know. So it's a very difficult thing to keep up in the first few months of life. But it's absolutely doable, and a lot of women, not a lot of women, some women do that. But there's a huge barrier in terms of energy to do something like that. But without the this was the problem that we had, that because there wasn't constant suckling, I ran out of milk after 3 months, you know. So and I'm someone who was highly motivated to breastfeed, right? I think I'm smart. I'm informed, you know, but it's really difficult. It's really, really difficult, and it's, you know, when you're a new parent. I mean, I could tell you, being a new parent and being overwhelmed by lack of sleep and this newborn that needs you 24 hours a day, it becomes very difficult. And anything that makes life a little bit easier is something that sometimes you just go for. But ultimately, it didn't make life easier. But it's hard. Yeah. Yeah. This falls into inappropriate to share, but I will. Yeah, no. I mean, I can tell you that in hindsight, in thinking about this, the things that I think led to poor latching from my daughter. This is my theory, but I had like a really protracted labor. I was not for a first labor, but I was in labor for 24 hours, and in the last like 4 hours, they gave me, my beautiful, wonderful midwives that I would have gotten a cesarean had it not been for them, gave me just a tiny bit of Pitocin, but then in order for me to take it, gave me Stadol and Methergin. Is that what it's called? There's another drug. I'm not remembering the name. What is that? Phenergen. Phenergen and a little bit of Stadol. And I really think that those drugs made her a little bit more lethargic immediately after birth, and so latching was a little bit hard for her, and she became lethargic very quickly in terms of not getting enough food. But I on top of that, the 36 hours I spent in the hospital was why things didn't work out. My stress level was through the roof because I just hated the hospital from the minute I got there. And then and this was actually a very highly rated hospital, you know, in New Jersey. Highly rated specifically for newborn care, you know, so for the postpartum period. But I felt like there were just people shoving my baby into my breast, you know, instead of actually showing me how to breastfeed her. And by the time I got to the lactation consultant, my baby had already lost like 11% of her baby weight, of her birth weight, and we were into bottles. And so for me, it was the first 3-4 days of her life and what happened in that period of time that then set up sort of a pattern that I take full responsibility for, but that set up a pattern of the path of least resistance was to not try. Yeah, that's what I could say. Last topic. So the renal system and the transition of the renal system. In fetal life, the renal system, like the GI system, developed actually very early, specifically because along with the GI system, it was important in recirculating or circulating amniotic fluid. Okay? So by 18 weeks, the main components of the urinary system is in place, and the baby is producing, or the fetus is producing urine. So very, very early on, this renal system is developed. The bladder fills and empties every 20 to 30 minutes in a fetus. Okay? And again, it's because it's circulating amniotic fluid. And so the fetal urine production is very, very high, even compared to the glomerular filtration rate happening in the baby. Okay? So in fetal life, the urine that the baby is producing is extremely hypotonic, so it's very dilute. Because this baby has a limited ability to conserve sodium and a limited ability to concentrate its urine. Okay? And most of that is a result of an immaturity in the medullary countercurrent system that's required to concentrate urine, and also a limited responsiveness to aldosterone. Now, these limitations persist in the neonate. So the urine that the neonate produces is also highly hypotonic. So the neonatal renal function has some really important limitations to understand. You have a decreased GFR compared to an older baby, an older child, or adult. So the baby is actually filtering less blood every minute of its life compared to what it will after a few months. You also have alterations in tubular functioning. So particularly when it comes to glucose and sodium handling. So the ability to conserve sodium, is decreased, as is the ability to excrete excesses of sodium. Okay. So the baby has a hard time conserving sodium if it's getting depleted, and it has a hard time of excreting extra sodium if there's too much. There's also, in terms of glucose handling, the baby has a reduced ability to transport glucose, okay, which is another way of saying it, has a reduced ability to reabsorb glucose. So you're more likely, under some conditions, to see glucose lost in the urine in a baby. And it has a decreased ability to concentrate its urine, which is another way to say that is that it has a decreased ability to conserve water. And that's because the medullary osmotic gradient has not been established yet. If you remember, in the medulla of the kidneys, you have this increasing concentration of extracellular fluid that helps you conserve water. So that's not been established yet in the neonate, mostly because the lengths of the loops of Henle have not matured. So you still have very short loops of Henle that can't establish that osmotic gradient immediately after birth. And the fact that the kidneys are not as responsive to antidiuretic hormone as they will be after a few months. So the implications for these limitations on function, the implications of having a decreased GFR is that babies are vulnerable to water intoxication. So if babies drink too much water, they can become, their plasma osmolarity can drop very quickly. And they have a decreased rate of elimination of bloodborne substances. Since most bloodborne substances, including drugs that enter the body or environmental pollutants, those sorts of things, they get eliminated through renal elimination. So decreasing GFR means that they will have a longer half-life in baby. Now, if you combine the decreased GFR with the decreased ability to concentrate urine, okay, if you combine the problems with GFR with the problems concentrating urine, not only is baby vulnerable to water intoxication, he or she's also vulnerable to dehydration. Okay? Which means that the baby's got a narrow margin for adequate hydration. Too much fluid, right, you get fluid overload. Too little fluid, you get dehydration. the baby has a hard time handling extremes. Baby just has a hard time handling extremes. The same thing is true with sodium handling. Okay? It has a very difficult time excreting extra sodium that's introduced or conserving sodium if there's a depletion. So narrow margin for sodium maintenance. Okay. And if there's too much sodium in baby's system, baby can suffer hypervolemia because the sodium, right, water follows sodium. So if baby's retaining water, it's getting fluid overloaded, and it becomes hypernatremic and all of the complications that come with that. And if baby becomes sodium depleted, water follows sodium, it becomes hypovolemic and hyponatremic. Okay? So very vulnerable to that. And because of a limited ability to transport sodium, this enhances this vulnerability to hypoglycemia. Okay? Glucose is more likely to get lost in the urine compared to an adult, so it is more vulnerable to hypoglycemia that way. Okay? So some significant clinical implications to the immaturity in the renal system. Okay?